I will start with some words about Norin, who is, as you heard, organizing this event in collaboration with others, and I will also share one patient case study with you. So, Norwegian Inflammation Network, it's a non-profit member organization dedicated to accelerate the development of new diagnostics and drugs in inflammation. And it is a venue for scientists, clinicians, innovators, and industry members that all share a common goal of curing inflammatory diseases. And we might not do it today, but in the future. So, what do we do? Norin is an innovation cluster within inflammatory diseases. And Norin promotes interdisciplinary cooperation and exchange of experience and knowledge. And I think today's meeting is one example of this. And we also want to provide matchmaking between research and development, financing and industry, bridging the gap between ideas and the market. So we have a very broad representation in the board of Norin with the clinicians, researchers, pharmaceutical industry, patient organizations and biotech. And we also have a very dedicated team running the daily business, and you have already met Björn and probably communicated with Tara, and Reidar is also taking care of the communication. And if you want to know more about Norin, you could visit our website. Norin is growing, and currently we have 75 member organizations. I am working as a rheumatologist at Diakonhjemmet Hospital, and I would like to share one patient case study with you to start this meeting. So this was a female patient with malignant melanoma of unknown origin with metastasis to the lungs, and she was diagnosed during the fall of 2015. She had a previous history of low-grade COPD and psoriasis, and otherwise she was healthy. And she was treated initially with dabrafenib and anti-PD-1 monoclonal antibody nivolumab from January 2016. And in September 2016 she was in remission. So at this time the nivolumab therapy was stopped by the treating oncologist due to polyarthritis, and it was seen as a probable adverse effect, and she was referred to our rheumatology department at Diakonhjemmet Hospital. And she presented with very severe polyarthritis. She had stiffness, joint pain, reduced function, extension deficit in the fingers, and numerous swollen joints, including MCTs, PIPs, wrists, knees, ankles, and MTBs. And this was also verified by ultrasound, tenosynovitis, synovitis, and joint effusion. And initial treatment included what rheumatologists do: intramuscular steroids, intravenous steroids, intra-articular steroids, and also prednisolone. And it didn't work very well. She was refractory to steroids, and there was only some short-term limited response. So what to do next? This was discussed with oncologists and also dermatologists, and we decided to start the disease-modifying anti-rheumatic treatment. So combining prednisolone, methotrexate, and etanercept. And this is just going through the patient records. You can see the number of injections with etanercept, the TNF inhibitor, and the prednisolone dose, and the effect as described by the treating physician. And as you heard, the baseline was quite severe polyarthritis, and she was followed quite tightly, and coming to our outpatient department after all these injections that I've written here. So at the second visit, she was worse. So we had tapered prednisolone from 40 to 30, and the joint pain and arthritis was increasing. But the next time, she was slightly better. And this improvement continued. And at the same time, as the prednisolone was tapered, she was still gradually getting better. And after 9 weeks, there was a definite clinical improvement. Prednisolone was now coming down to manageable doses, and still, after 11 weeks, there was only clinically monoarthritis and flex retinosynovitis. And after 15 weeks, and that was actually last week, there was still activity, but the clinical situation was much improved. So we don't have very much experience with this within rheumatology, but during the last couple of years, there has been some case stories. This was published last year. It's based on US experience, among them Johns Hopkins Hospital. And as you can see here from these 9 patient cases, the clinical picture is quite similar to the patient that we had at the Diakonhjem Hospital. So, to summarize, this was a patient with very severe polyarthritis, refractory to steroids. Initially, there was some questioning if this could be a differential diagnosis with psoriatic arthritis, but quite uncommon presentation and also uncommon response to therapy. And it was concluded that this was an immune-related adverse event and then related to treatment with the anti-PD-1 monoclonal antibody. And the therapeutic choices was discussed with treating oncologist, and she had a slow but gradual response to combination therapy with methotrexate, etanercept, and prednisolone. And we are absolutely certain that we need to learn more to better handle these situations. So I'm looking forward to the rest of this meeting, and Björn, you will chair us through the rest of the afternoon. So thank you.